Hello. This session is to talk with patients and their caregivers about the lung transplant surgery and some of the decisions and logistics around it. You'll usually meet one of us, the surgeons, near the end of your evaluation in preparation for going on the wait list. The patients seen by the surgeons are usually almost done with their evaluation and near discussion for being put on the transplant list. This is usually one of the last clinical stops. We have several transplant surgeons, all are experienced and well-trained and rotate through call duty for the surgeries. So we are interchangeable, as much as I hate to say this. You will not be able to pick your surgeon, as it will depend who's on call when the right donor offer comes for you. We hope that by the time you watch this video, you already know most things about transplant and what's involved. We assume that you know that lung transplant is a treatment option and not a cure. It is a rather dramatic treatment option. It is one of the biggest surgeries you can have. The two biggest risks after transplant are rejection and infection. You will be on medicines to suppress your immune system for the rest of your life and medications for infection. These medications have side effects. There will be a lot of testing and visits with us to help take care of your new lungs even after you leave the hospital. You will need a caregiver team to help with your recovery. You will need to call us every time things aren't going according to plan, no matter how long after the transplant. And that you work with us and follow our instructions on how to care for your new lungs. So now I would like to share some things you may or may not know in preparation for listing and surgery. While you're on the list, you want to stay as healthy as you can. We know it's hard. We may instruct you to lose weight or gain weight, among other things. Keep exercising. The better shape you're in going into surgery, the better your recovery will be. Donor allocation depends on several factors, including your blood type, height, your antibody profile, which we will discuss a little bit more. It can take an average of 3 to 6 months to find an organ for you. Your time on the wait list also depends on how many other patients are waiting on the list with an allocation score higher than yours. In general, the higher your score, the higher on the wait list you are, and the more donor offers that will come for you. You get a higher score if you're very sick. All the testing you've done so far, we put into a nationalized computer system, the UNO system, United Network for Organ Sharing, and it generates your score. That's how you get ranked on the waiting list. There are some factors that may delay finding suitable donor lungs for you, including, but not limited to, number 1, COPD or emphysema. The score for a patient with this kind of disease is usually low, so it takes longer to find organs. 2, antibodies. Antibodies are proteins in our blood that help us to find and attack foreign things like viruses, bacteria, etc. They develop from exposure we have had in the past to someone else's genetic material, for example, blood transfusions, pregnancies, transplants, and sometimes even major infections. Having antibodies against other people's genetic markers makes it more difficult to find organs that your body will not attack or reject. The more antibodies, the longer it takes to find the right donor lungs. Unfortunately, these antibodies are not something to be fixed. We just have to wait longer to find the best match for you. And 3, small stature. If you're a petite person, especially if you have a fibrotic lung disease like interstitial lung disease or pulmonary fibrosis, your chest on the inside may be even smaller than we would normally expect. Let's say you're 5'4" tall. If you have fibrotic lung disease, your chest on the inside may be more the size of someone who's 4'8" tall. It may take longer to find an organ that's going to fit inside such a small chest. Oftentimes, we will consider trimming the donor lungs down to make them fit inside your rib cage. Now, while we're talking about size, if you happen to be a person with COPD or emphysema who's 5'4" on the outside, you may have the chest of a person who's much taller, like a 6-foot tall person, on the inside because COPD causes the lungs to become bigger over time. We cannot grow the organs bigger yet, but we can trim them down. There are really no disadvantages in trimming the donor lungs down. We've been doing this for a long time because we have a big population of patients with fibrotic lung diseases. In theory, there are risks for infection and air leaks, but they have not panned out. How do we select a donor? I already mentioned that it depends on your blood type, your size, and your antibody profile. What type of donors do we accept? Most of our lungs come from donors who have been declared brain dead, and they and their family wish to donate their organs. I would say 90 to 95% of donors are brain dead donors. There's a small minority that are not brain dead yet, but have a brain injury from which they cannot recover and survive. Under these circumstances, the donor may have given instructions to their family and in an advance directive that if they were going to be dependent on life support, they would not want to live that way. So the family has made the decision to withdraw care. In this situation, care is withdrawn, and when the heart and circulation stop, they are declared a DCD or diseased by cardiac death donor. If the donor passes away within a certain period of time, the organs may be good for donation. In this sort of scenario, I would say that the chance of the organs being good for transplant is about 50-50. If the donor doesn't pass within a certain length of time, we are somewhat reluctant to take those organs because despite a lot of information we have looked at, we can never quite tell how this will work out. The third way to get organs is on what we call ex vivo lung perfusion. You may hear lung in a box. So what is that? Occasionally we will be in a circumstance where the donor family has given the procurement organization too little time to either fully assess or make all the arrangements necessary for a smooth donation process, and we still don't quite know if the organs are good or not. Either way, we take the organs out of the donor and we put them in the machine outside of the body that oxygenates and gives nutrition to the lungs. So there's both circulation and ventilation going on. Then we have several hours to look at the organ function to see if we like it or not. All the criteria for the donor organs that we recover in the standard fashion have to be met for these lungs in the box or ex vivo organs on the device. We were part of an international clinical trial several years ago. We did several organs on this device with excellent outcomes. When the trial ended, the results were so positive that it's now an FDA-approved device and has become the standard of care and no longer requires consent from the recipient to use it. We've been able to successfully use lungs that were maintained on this device for many hours and have good recipient outcomes. Single versus bilateral. We can transplant either a single lung or can transplant both lungs, bilateral lung transplantation. There are a lot of factors that go into that decision, and sometimes the decision happens at the time of the donor offer. You will not be able to decide whether you get one or two lungs. You should prepare yourself to be called in for either. You're giving us your permission to make the best decision about the correct donor option for you in terms of single or double, and also in terms of all the other information we review about you and the donor. Donors with at-risk behaviors. What does that mean? There previously was a category of donors called high-risk or increased-risk donors. These are donors who have some risk for having blood-borne infections. We now call them donors with at-risk behaviors. Some examples of what makes a donor at risk for having a blood-borne infection include somebody who sells sex for drugs or money, so they may have a lot of sexual partners, somebody who was in prison and exposed to all different kinds of things, or an IV drug user where they may have shared needles. These people are at higher risk of having an infection, and so there's a higher chance that some infection could pass to you with the donated organs. It could be HIV, hepatitis B, hepatitis C, etc. We do accept organs from such donors. About 20 to 25% of our donors are in this category. These days, the tests have gotten really, really good. So if the donor has tested negative despite these risk factors in their history, we will notify you, but will strongly encourage you to proceed with the transplant. It's a very, very rare circumstance, and I'm talking about less than 0.3% that something will be passed on to you, especially when the testing is negative. So 99.7% of the time, you're going to be just fine. You're monitored very closely over the next year to make sure that you haven't contracted something infectious from the donor. If there were an infection contracted from the donor, it would show up within this first year. We do consider donors who have a history of hepatitis B or C, and even donors who test positive for hepatitis C, as these are very treatable conditions now. The cure rate is greater than 95%, and the outcomes for using these lungs are the same as with donors who are negative for all. Thus far, we are not accepting donors who have HIV. Now, people get very nervous when we tell them that this is an at-risk donor, but I want to put your mind at ease today. As I mentioned, the overwhelming majority of our donors are brain dead, so we are depending on family and friends to give us information about the donor's IV drug history, if they were in prison, or those kind of things. What if somebody doesn't tell you, or if they don't know? So every donor gets tested the same, as if they were at risk for infection, since there's some risk with every donor, even the standard ones. As I mentioned, approximately 25% of our transplants are from such donors, and thus far we have seen little, if any, infections transmitted this way. The risk is very, very small, so the odds are in your favor. The last thing I would mention about these at-risk donors is that if you're really sick with your lung disease and we bring this offer to you and you don't take it, especially if you happen to be small, your score is low, or you have very high amounts of antibodies, this may be your one and only opportunity to get an organ. I hate to say this, but there were 2 patients over the past 10 years who kept turning down these at-risk donor organ offers. These 2 patients kept turning the increased risk donors down, and by the time they said, okay, I will take it, we didn't have any organ to offer, and they did not survive. By the way, this is the only time donor information will be shared with you to let you know of a behavior in the donor that classifies them at risk for infection. We need to give the donor's family privacy and time to grieve their loss. So you will not be told about the donor, not how they died, or anything that is not pertinent to your care. On the rare occasion, we may talk with you about something specific that comes up outside of these at-risk behaviors. Something like an allergy the donor, or a cancer that was found in a different body part of the donor. This is not common, but if we know the donor's history, we would discuss it with you before the surgery and usually before accepting the lungs for you. I can tell you that once you become part of our transplant family, you're in it for life. I think of this like a marriage in many ways. We're in this together until death do us apart. Once you're in, we're going to take care of you. We need your faith and trust that we are going to do the right thing by you. We're going to do our absolute best to pull you through. And we need to be able to trust that you will take good care of these new lungs for the rest of your life. Always have a bag ready to grab and come into the hospital. Sometimes we don't have much time to get you here from home. We always want you to drive safely. Once you arrive at the hospital, there's a lot of wait and see going on, in the sense that we even don't know what time things are going to happen. We get a ballpark time that we think things will happen with the donor surgery. About 20% of the time, you will have what's called a dry run, which basically means that you come into the hospital for transplant, but the transplant does not pan out, so you go home. It could be for any number of reasons. We send out our retrieval team, and when they look at the organs with their own eyes, the organs aren't good, so we back out of the offer. Occasionally, depending on how far the donor hospital is from us, you'll be waiting inside the operating room and still come out without a transplant. Let's say that everything's okay. It's It's a green light, it's a go. At this point, you're in the operating room and you undergo general anesthesia, meaning you sleep through the whole surgery. We tend to do double lung transplants, but for recipients over the age of 60 or 65, it doesn't make that much difference in the outcomes. However, if you happen to have cystic fibrosis or severe pulmonary hypertension, which means high blood pressure in your lungs, we absolutely must do a double lung transplant. For all the other conditions, we can do a single lung transplant. Older patients recover faster with a single lung transplant, as a double lung transplant is a bigger operation. In our program, we open the chest horizontally, generally below the breasts or nipples, and we cut through the breastbone. You will hear this called a clamshell incision. Most of the time, we put the patient on a heart-lung machine called ECMO. ECMO stands for extracorporeal membrane oxygenation, and it's essentially a machine to keep the blood oxygenated while we're doing the surgery. On rare occasions, we put you on full heart and lung bypass like they do for heart surgeries. There are risks involved with either type of bypass machine, but on the order of less than 1%. They include stroke, kidney failure, multi-system organ failure, heart attack, infections, injury to adjacent structures, etc. We replace one lung at a time. When the operation is done, we will close the chest up. There'll be tubes in the chest to drain fluid, blood, air, etc. In small percentage, about 5 to 7% of the cases, we choose not to close the chest at the end of the original operation, and that's for any number of reasons. To name just a couple reasons why the chest may be partially closed: one, it could be because the lungs are swollen, or perhaps the lungs are too big, even though we have trimmed them down. So there are any number of reasons why we may choose to leave the chest open. I know this sounds really scary, but the recipient is usually going to be asleep, although not always, and their pain well controlled. We will usually go back to close the chest within the next several days. You will also have other equipment like a catheter in your bladder to collect urine in a bedside bag, and a large IV in your neck or shoulder area that we put in during the surgery. So you're in the intensive care unit now. After coming out of the operating room, you have the breathing tube in. Depending on how your brand spanking new lungs are performing, we will decide when to take out the breathing tube. Usually within 24 hours to sometimes within 48 hours if you happen to have pulmonary hypertension. Whether the tube is in or out, as long as you're doing okay otherwise, we will probably get you out of bed. The most important thing in your recovery is strength, stamina, and rehabilitation. So we will want to start rehab as soon as possible so that you can be on your road to recovery. On the average, you'll stay in the intensive care unit for around 4 days or so, where you can be watched and monitored very closely. You'll get daily bronchoscopies done to make sure that the lungs are working well and healing well. A bronchoscopy is a procedure where we pass a camera through the upper airways down into the lungs to take a look around to check for infection. We can also clean out any debris or secretions from the new lungs because you won't be coughing very well to clear this out on your own yet. If everything is going well, you'll get out of the intensive care unit in 4 to 5 days and go to the step-down unit. Here, it'll be quieter and more private. That's where you'll spend the rest of your hospital recovery. This is where we will work on getting you stronger, getting you accustomed to the new life with new medications, etc. If everything goes well and the chest tubes are out, you'll generally get out of the hospital about 2 weeks after the surgery. When you get out of the hospital, you have to stay close to us for the next 6 weeks because the body is going through a lot of changes and medications, doses need to be adjusted. The organ functions need to be monitored. Sometimes the hospital stay may be longer because the chest tubes have too much drainage, but generally we can get you out in about 2 weeks. Among other things that can happen after transplant, there is something that nobody has figured out why it happens, but it happens. Thankfully, the incidence is not very high, so odds are in your favor. But this is something you do need to know. What is that? It's called primary graft dysfunction, or PGD. It basically means that the new lungs are not working well. Why are they not working? Nobody really knows why it happens. There's a lot of research going on in the field, including at our program, but so far nobody really knows. It usually develops within the first 72 hours, but could develop any time during the first week or so. It could be mild, moderate, or really bad, severe PGD. It happens about 25% of the time, no matter where in the world you are. So, what can we do if PGD happens? An overwhelming majority of the time, it is the mild to moderate form of PGD that may mean a little bit longer time on the breathing machine, but you'll come through and you'll have the same length of hospital stay as someone who didn't have PGD. In rare circumstances, up to 15% of the time, it can be a severe form of PGD. This can be life-threatening. Generally, about 30 to 35% of patients who develop severe PGD don't make it. In our program, about 80 to 85% will make it. The reason I would say is severalfold. Number one, if we see any signs of it developing, we're very quick to respond. We're quick to support you on the ECMO machine we talked about earlier. This allows your new lungs to rest and recover while the machine is doing the work for the heart and the lungs. If we don't support the lungs and sometimes heart with the ECMO machine, they get damaged more and more by the increasing pressure on the breathing machine. We can connect the ECMO machine to you in different places in the body. Sometimes it can be in the neck, other times it can be in the leg, and occasionally we'll leave it in the chest. Sometimes we may even come out of the operating room with the chest open with the machine tubing coming out of the chest. It's scary for the family to see. You're more than likely going to be asleep through this, but it's scary for your family to see. I can tell you that we will do our absolute best to pull you through. We will guide your family through all of this too. We'll be honest with them. We will let them know if this is something temporary and we expect things to go well. But we will also tell them if enough is enough and we need to start talking about end-of-life decisions. If you're really sick and on ECMO, you can have multi-system organ failure. The heart, kidney, liver, lungs, anything can fail if you become that critically ill. Stroke can happen. If we put the ECMO tubing in your leg, in extremely rare circumstances, you can lose the function of the leg and even sometimes lose the limb. We did have this happen once, many years ago, and we implemented several monitoring protocols to try to prevent it in the future. It is extremely rare, but it can happen, and it has happened, no matter where in the world you are. Are there other conditions that put you at higher risk for PGD? Yes, there are some factors, but we don't know all of them yet. If you're overweight, that will put you at risk for developing PGD. If you have pulmonary hypertension, especially severe pulmonary hypertension, that will put you at increased risk for PGD. Smoking history also puts you at risk for PGD. If you go into the operating room very, very sick, that will put you at increased risk for primary graft dysfunction. There are some donor factors that may contribute to the risk of developing PGD too. Nobody fully knows all the risk factors that put you at risk. So what can you do from your standpoint? Keep your weight down, keep your oxygen up, so you're not developing pulmonary hypertension if you don't already have it. If you have it, there's not much we can do. We can give some medications a try and see. Not every person who has pulmonary hypertension develops PGD, just increases the risk of getting it. If you need prolonged support on the breathing machine, and this can happen with or without the need for ECMO, we will perform a tracheostomy, which is a tube placed directly from the neck into your windpipe. We do this because having the tube in the mouth can be uncomfortable and it leads to long-term complications. The tracheostomy tube, however, is more comfortable and has a lot less complications in the long run. Having a tracheostomy is temporary. Once you recover and no longer need to be on the breathing machine, the tube can be removed from the neck. This small neck hole, the size of my finger, heals closed by itself, and you can breathe normally through your nose and mouth. If the breathing tube has to stay in, or if we put in a tracheostomy, or if we think that some of the food from your stomach may come up and soil the new lungs when you eat or drink, we may put in a feeding tube. We also do this if we know that your esophagus is not working well, as is common with scleroderma patients. If we think this will be for a short time, we will put a temporary tube through your nose down into your bowel so that we can bypass the esophagus and stomach. This will allow us to get you the nutrition you need to be able to heal best, and also give us a route to get medications into your system, but will minimize the risk of damage to the new lungs. Let's talk about how we control your pain, because this is a massive operation. Several years ago, we started freezing the nerves inside the chest during surgery. We freeze the nerves on both sides if you do undergo double lung transplant, and we have had very good success managing the pain after surgery. If the pain isn't well managed by this nerve freezing, we may need to place an epidural catheter in your back. That's the catheter that women sometimes get during childbirth for pain control. So on rare occasions, you will end up needing the epidural, even though we freeze the nerves. The effect of the nerve freezing or cryoablation, it may last for several months. You will still have pain, but the pain can be managed with less medication. And that's important to make your recovery smooth. Transplant's a compromise. Once it's done, you're on medications forever, and it's not negotiable. And there's a lot of them. And the medications have side effects. Change your eating habits, make your bones brittle, make you more susceptible to infection. They can cause cancer, like skin cancers. They can make you prone to bruising and don't let you heal as easily. Is it worth the compromise of taking these drugs forever to get rid of the struggle with oxygen? Initially, there's high levels of the drugs, and eventually we wean them down. Some wean off, but in the beginning, much of your and our time will be about how to manage these drugs and their side effects. You must follow instructions very carefully to preserve these lungs for as long as possible. In real estate, it's about location, location, location. In lung transplantation, it's about walking, walking, walking. Walking to expedite your recovery, walking to exercise your new lungs, walking to get you out of the hospital. We will have our physical therapists work with you on a plan to get you up and moving more every day. It's time to get up and use those nice new lungs you got. So in conclusion, we know that your lung disease is end stage and progressive, and that your current quality of life must be suffering for you to consider this option. Before we list you, we need to make sure you understand fully what's involved and that it's the route you wish to pursue. Every single team member is here to ensure you have the best outcome. I hope you have found this information useful. We encourage you to watch it again and to share it with your friends and family so that they are as prepared as they can be too. We would also encourage you to review more information at lungtransplanteducation.ucsf.edu. Please contact our office with any questions at 415-353-4145. Thank you.